So I would like you to ask your question. So for the von Hippel-Lindau, would you recommend the OCT-A systematically, or you still do angios, I imagine?
For all cases of von Hippel-Lindau, even now we stick to angiography. OCT-A was, our idea was to just evaluate how does it look on OCT-A. But right now with the only 9 into 9 mm scans, we will not be able to, definitely it's not in a position to replace angio. We do angio in all cases of von Hippel-Lindau.
And so you manage to see the peripheral tumors? Can you manage to see?
We can manage to see peripheral tumors which are missed on clinical examination, definitely.
Good. Professor Godric perhaps could tell us his experience on treating von Hippel-Lindau's and the interest of OCT-A for evaluating the von Hippel-Lindau treatment.
It depends on the location of the tumor, and it's true that with wide field OCT-A we may have nice images of this angioma before and after treatment, and I appreciate the very good presentation and the superb image we have seen. By looking also at the diameter of the feeder vessels, it also a good indication of the quality of the treatment of these vascular tumors.
Okay, thank you. The problem with tumors is the correlation between exudation and the vessels we see with in the choroid. So it's always disappointing to see that there is not always a correlation. Was it your experience for hemangiomas, for example?
In most of the cases which we saw, the tumor vasculature did correlate with exudation. So whenever there is an exudation, usually the vascular density or even whatever the vascular signal we are seeing on the OCT-A was more when compared to other cases in which there was no exudation. That had a correlation in our series.
I think we can evaluate choricapillary circulation and upper choroid vessels, but we
probably
still can't evaluate the deeper vessels and the effect of the treatments.
Yeah, one limitation of our study was what we did was we segmented the entire tumor. We included from the uppermost layer of the tumor to the lowermost layer until which it is visible. We didn't segment it separately. We did separately in a series of choroidal osteoma in 5 cases of choroidal osteoma, in which we can actually identify that the choroidal vessels enter the choroidal osteoma at a deeper level. They grew through the tumor and came into the superficial layer. They arborized there. And in cases in which they were associated with CNV, they were communicating with the CNV also. We have published this article in Ophthalmology 1 year back. Can you, ma'am, in your series, did you see any communication between the intrinsic vasculature of the tumor and of osteoma and the CNV?
No, we didn't find this connection, but perhaps for limits of the instrument on our acquisition. But we have also 3 cases of choroidal osteoma with no subretinal fluid and no CNV, and is silent for the time.
But I think in osteoma probably, like, we need to do a segmentation to see like whether there is a communication between the intrinsic vasculature and the CNV, because there is one paper in which they say that if there is a communication that indicates that it's getting extensive vascularity from the tumor vessels, so it is one of the most resistant CNVs of all.
I'll try to change
that probably with the segmentation you would be able to identify.
Okay. And it was very interesting also to see that with decalcification of the tumor, you have chronic exudation that you treat by calcium intake. So what are your criteria to say that exudation is linked to decalcification? Is it
in the past, the unique criteria is the presence of subretinal fluids, but from the new studies that correlated the subretinal fluid without activity CNV, we study also OCT angiography, and OCT angiography is for our clinic a useful criteria to decide to continue or stop the intravitreal injection. So in the second case, we decided to stop the intravitreal injection because we don't see an active CNV.
And so, what is the calcium intake, and what is the effect you should observe when you take calcium? In the cases with chronic exudation linked to decalcification of osteoma, what is the recommended calcium intake? And
it is important that the subretinal fluid co-localize with the area of decalcification, because if there isn't this association, perhaps the subretinal fluid was connected with the active CMV. So the correlation with decalcification is very important to decide the strategy, the therapy strategy.
And so what is intake recommended?
We performed always